Hi, Caroline. Hi, Rob.
Good morning. Afternoon,
Hello.
actually, now.
Yeah.
So while we're just waiting for the last people to join, those of you that are speaking, we've made an executive decision that we're going to do the talks one after each other, and then we're going to have all the questions at the end, if that's okay. Just thought that would be easier potentially for timekeeping. Thank you. So hopefully everyone can see the joining slide. So you can see the order of play. And if you could all introduce yourselves in the chat, or if you have any questions, that would be great. And then we will either round them up. If there's a, we can either do hands at the end, or we can pick them out of the chat, if that's okay. Right, it's 1 minute past midday, so I think we're going to kick off. So welcome to our second session for AHP's week. My name's Rhoda Allison at Torbay in South Devon, so I'm chairing the session today. I'm going to remind the speakers that we're going to be very strict with timekeeping. So I will give you, you have 10 minutes to deliver your session. I will give you a 9-minute warning. So it'll be a verbal quick of you, that's your 9 minutes. And then we'll be asking you to make your closing comments, just aware, because there's 4 sessions that we need to fit in. So thank you for your support with that. So welcome to everyone else. We're delighted that we're going to be joined by Rob Davis today, Catherine Bamforth and Richard Collins, Mandy Tuckey and Amy Caulfield. Thank you all for agreeing to speak about the projects you've been doing to develop AHPs. I'm going to introduce our first speaker, who's Rob. Rob, I'm going to take down my slide and pass over to you, if that's all right.
Great, thank you. So I'll just get my presentation up, hopefully. So hello everybody. So my name's Rob Davis. My role is as a specialist practitioner for the Parkinson's team at Derriford Hospital. Professionally, my background is as a physiotherapist. And so I'm really keen to kind of help break down the barriers that exist for a lot of people, because a lot of roles have traditionally been held by nurses, and actually, you know, as AHPs, we offer a lot more and can support that and develop services. So kind of how I got here, I went to university in Plymouth and graduated way back in 2011, and my very first job was in Torbay, where I started in the community, and I did all my rotations, loved them all. No specific kind of interest, just kind of did a bit of everything, see what took my fancy. I then got a job in Plymouth at was Plymouth Hospitals Trust then, but now UHP as a band 5, then progressed up to a band 6. And I've taken on additional roles, and this is the other thing as well. You know, it's not just clinical roles. I'm both a local and regional steward for my professional body and trade union, which is the Chartered Society of Physiotherapy, and definitely would push being a member of union certainly at the moment. And then just recently, I completed a secondment for a year as a band 7 lead for our intensive care rehab team. And that was certainly an interesting time, because that was just as COVID first arrived on our shores and through those initial waves. But the reason I'm kind of here today in that is because actually at the end of last year, I secured a post as a specialist practitioner with our specialist team here at Derriford, where I now work and sit under the neurology directorate. And I've also recently completed the non-medical prescribing, which is something that we're pushing quite heavily across the trust. And I would urge anybody to kind of do if possible, because I'm just waiting for my paperwork to kind of get through and get ratified so I can get on the register. But it really helps in terms of understanding patient conditions and managing them, and being able to provide support to teams and medical services. So the service as it was established back in 2016 and was set up by 2 nurses as a result of some funding through the Trust and Parkinson's UK, and they've done really well, and they've won awards and really kind of set the scene. And when you go elsewhere in the country and talk about Parkinson's, they do ask and refer to the service, which is great. but for years I was pestering them. Like I said, I wasn't particularly focusing on one area, but I've been a band 6 for a few years, and then one of my colleagues, my seniors, said you kind of need to think about something to specialise in. So I was having a look round, and I looked at what we had in trust, because I quite enjoy working at Derriford, and I noticed that we had neurology specialists in spinal cord injury, stroke, MS, brain tumour, but nothing for Parkinson's. So we started to look at that, and then I started to pester the team about trying to get a physio onto the team and put a business case in for that, and was in the middle of working on that when one of the nurses retired. And last year they tweaked the job spec to broaden it up and introduce the role of the specialist practitioner, so the equivalent to the specialist nurse essentially, to improve, kind of broaden the skill mix on the team. So I've been in post now for just under a year, still get referred to as a nurse a lot, but that's kind of a badge kind of where we're on and out, although in our meetings everyone's used to me saying I'm not a nurse, and that's kind of an ongoing thing, and we've achieved quite a lot. So over the last year, we've introduced a number of changes. We've had a rebrand, so because it's not just about nursing, like we said. There's myself, we've got an assistant practitioner on the team as well, and he's looking at doing some additional training, and he may or may not do nursing, trying to encourage him to do an AHP role. So we've rebranded as the specialist team to reflect that actually we are not just about nursing, and as we want to grow the team going forward, we want to incorporate different roles of the MDT as well. We've done a number of initiatives, and these are some of the things that the nurses have wanted to do prior to getting on board, and that's improving like patient safety. But there's been some things that have been initiatives taking on board the experiences that I've had previously, and things that I've done in other roles, and just kind of ideas really. So we've introduced alerts when patients get admitted, so that we know that they've come in and they've got Parkinson's, that they're on medication, that gets flagged up, and this is all to help the MDT in terms of identifying and making sure that patients get their medication on time. Also reviewed the resources that wards have, including guides about the medication, where to get hold of it out of hours, so they can refer to us, and we have an electronic referral scheme we brought in. But if we're not around because it's the weekend, for example, and they've got questions about drugs and they need to know where to get it, they now have the resources to do that, which helps improve patient safety. We've also started updating our website to make it more patient friendly, but also provide a resource for healthcare professionals in and out of the hospital. So that's available for anyone to access, because not everyone needs to be able to access it on a trust computer. We've taking part in initiatives such as World Parkinson's Day. We're really trying to push and raise awareness of Parkinson's, and part of this just comes down to having extra staff as well. So in Plymouth, we managed to get the Theatre Royal lit up blue, and also the front of the hospital. So next year the plan is to try and get a couple more buildings lit up, and eventually we'll get there. And then we've also have started to get some collaboration and run some events for people that are newly diagnosed with Parkinson's. So through having come in externally, I was able to identify that there'd been a bit of a gap with people being diagnosed and the length of time it was getting to see a clinician, and the kind of void that left them in, and not knowing about what Parkinson's was and how it could affect people. Patients were kind of looking in the wrong places, or not knowing what to do or where to go. So we've introduced, and in conjunction with some support from some of the pharmaceutical companies, some newly diagnosed patient afternoons where patients can come along and we give them some advice, information about Parkinson's, how to manage it, what you can do to improve quality of life, how to embrace it, how to engage in activity and exercise. And it means that when we see them in clinic, typically 4 or 6 weeks later, they're in a better position to do that. Going forward, we've got more plans, and this is where again, it's that kind of multidisciplinary approach is really, really key. We're looking at increasing our kind of range of treatment options we offer. So we want to be able to offer and refer for DEXA scans. We've got our colleagues who offer treatment options via research. We want to improve our integration with them and have a better understanding of that, which will also help us in terms of clinicians. We're reaching out and liaising with our colleagues in primary care, in GP surgery, and also in SWAST in terms of supporting education to help see if we can prevent people being admitted. We're again looking at more training for individuals, expanding the MDT. We're also looking at introducing hopefully some physio clinics to try and bridge some of the gap we have at the moment between what's available in the community for patients and what we can offer. And then also look at what other things are around in terms of trying to become essentially a centre of excellence here so that we can kind of become a one-stop shop for patients. So to that end, we recognise it's about empowering people and making things available for them. And I think it's very much fits with what I think is a very physio approach of being holistic, where we've got some fantastic neurology colleagues who are amazing at their job, but they are quite neurology and Parkinson's focused. But on the other hand, we've got some amazing geriatricians who help provide us oversight and clinical support, and they have a more slightly holistic approach. And it's getting a marriage and a balance between the two of them, really, and that's really, really important. And they're all really supportive of what we're doing. So I think, I just want to kind of show that just because roles have been nurse-led previously, and a lot of things are either nurse or medical-led, they don't have to be. It can be hard to make that change initially. And a lot of what I do at the moment is still kind of along the nursing pathway because we're having to change pathways and we're having to introduce new schemes. But that takes time. But the time and energy you invest in that will reap long-term rewards. And certainly we're starting to see some benefits already. And long-term, if we can kind of work on our strategy, I think the outcomes for patients will only get better. And in terms of integrating our services with the community services, in terms not just for patients, but in terms of staffing. And then that obviously offers more opportunities for career progression. And at the end of the day, that's what we're here for. Yeah.
It's just your end of time warning.
Fab. That's all right. And
I'll let you wrap up.
That was me. So that's it. I've got nothing else to say. Thank you.
Thank you.
Cheers.
Thank you very, very much.
I'll just stop sharing.
Thank you. That was brilliant. We're going to save questions until the end of the presentations, if that's all right. So we're going to move on to our next speakers. Thank you so much, Rob. Next to welcome Catherine Bamforth and Richard Collins. I'll let you introduce yourselves, guys.
Hi, can you hear me, Rhoda?
I can hear you now, yeah.
Hi, and I'm hoping that you can see these slides as well. My name is Catherine Bamforth. I'm a clinical research team leader and physiotherapist at Torbay Hospital, and I'm here with my colleague, Dr. Rich Collins. Rich, I hope you're also on the line still there.
I'm still here, thank you. Hiya, I'm Richard. I'm a podiatry team lead, and I dabble in lots of areas, but one of the areas I'm really keen on is developing clinical research.
Thank you very much. And we're here today to just talk about our passion for research, essentially. Research is a very broad church, and if people are interested to talk about specific research training, doctoral pathways, we're very happy to have that conversation. But our particular topic today is about some entry-level, dipping your toe in kind of opportunities that we've created at Torbay. Really happy to talk about how you might develop these in your organisations if you're interested. So two specific schemes for dipping your toes into research we want to talk about are the Chief Nurse Research Fellowship and also the Associate Principal Investigator Award. The good thing about both of these schemes is that there's no assignments, there's no marking or grading. Oh, sorry?
Sorry, that's time to mark.
Oh. Sorry. Hopefully that means that these are not intimidating, very easy to access, and also great opportunities to within your jobs start to incorporate some research into that. So just pass over to Rich to talk us a little bit through about where our Chief Nurse Research Fellow Award began.
So there's been lots of funding, and when those of you in research know, there's always lots of opportunities. And so what we found is that in 2020 and 21, the Clinical Research Network had some small grants that became available to try and build some capacity and capability of research into your workforce, which is one of the main aims, both nationally, regionally, and locally. So we were very successful with applying for that, and we use the chief nurse as our main ally within the board level, and the chief nurse is someone called Deborah Kelly within Torbay, and she at the moment is the lead of the AHPs. Something hopefully that she's really proactive in developing AHPs as we move forward. So back in 2020, we managed to think about how we could use these small pots of money to try and encourage people into dipping their toes and start the journey. And so therefore it's a little bit about practical skills of clinical research delivery, being mentored. I have the privilege and opportunity to mentor a couple of the chief nurse research fellows, and I learn all the time, and it's fantastic. We ask that they undertake a service improvement project, and so therefore it's about an achievable project within a short space of time. And there's also this link with clinical academics, so linking to higher education institutions such as University of Plymouth or Exeter, and that's where part of the mentorship starts to come in, because we tailor it to an individual rather than just a very general plan. It's very bespoke. And we've been really successful in that. We've had several different sorts of different research associates, both nurses and midwives and AHPs, which have been fantastic. And we've also supported an exchange, a cafe exchange, which we call it on a Friday afternoon once every 2 months, where we get together and we just discuss what the problems are, solution focused amongst ourselves in a very safe environment. Next one, please, Catherine. And these are some of our successes. So the first two that went through the program was someone called Rebecca Stride, who's a CT radiographer, and then James Bruce, who's an occupational therapist working in intensive care unit. And Rebecca's first project was optimizing CT scan for cancer patients. And what she found is that they could reduce duplication of visits in what is a really traumatic experience, and basically improving the patient journey. And those of us with the business minds on reducing duplication of visits means a financial saving of somewhere along the line, especially in CT scanning where the service is already pressed. And the amazing thing about Rebecca, and we've alluded to it already as the start of a journey, is that she's found that she'd really been inspired by the journey, and she's gone on to successfully develop both her clinical skills, her leadership skills, and academic skills, and has been successful in funding more research. And the other thing I'd like to say is that Rebecca's an amazing advocate for research and has attracted lots of research studies to Torbay, and for that it's great when you look at research embedded studies, is that it really improves the patient experience. James, I had a privilege of supervising, and what an amazing little man he is, in the fact that he is just a mine of information and ideas, and this was just his first step in stepping out of his normal clinical role, and he actually interviewed patients with lived experience of their intensive care stay. He ran a couple of focus groups, something he'd never done before. He undertook the focus groups. He'd used cinematic analysis through to understand what their problems were, and what he found is that actually contradicted a lot of the pathways already in place. And so, alongside the IM intensive care team, they've actually changed a lot of their existing pathways based on this. Again, he's just going strength to strength. He understands the power and the strengths of clinical academic work, and so now he's again been successful in obtaining more funding to clinical research moving forward. Next one. And these are our next slide, Catherine.
Sorry, yeah, yep. Sorry.
And these are our current awardees, and Jess is a physiotherapist looking at patients with upper limb hemiplegia following a stroke, and so she's just at the first starting of her pathway. And she's had her first supervision meeting with myself and Catherine. Again, really inquisitive mind, lots of ideas, and you can see that she's already started thinking about external modules of her own particular development. And Rianne is a CT radiographer, very similar to Rebecca's stories, really, in that she's realised that there's in Torbay we don't actually follow some of the nice guidance and best practice for patients undergoing CT colon. So again, duplication of visits, poor patient journeys, and therefore she's challenging some of the existing pathways to see whether we can change this. I think what all these four show is that there's a diversity of professions with a range of so different niche clinical areas that are being examined. And it's about personalised training. It's a wider range of courses and opportunities, but effectively we're developing the leaders of the NHS for the future, and it's such a wonderful thing to be able to get involved in.
Thanks, Rich. So I just want to quickly finish our talk by talking about the Associate Principal Investigator Scheme. And this is a great way, if you're interested in research, to not have to get too bogged down with writing your own protocols, designing your own research methods to instigate a programme. These are already research studies that are currently in existence. And it's a way for you to think, you might have been to a conference, you might have heard people getting involved in other types of clinical trials or studies, and think, actually, this would be a great one to run in our department. So it's a way of the clinical services working alongside research and development. Each hospital site would have a principal investigator who's in charge of the study in your particular organisation. The associate PI scheme means that you work alongside the experienced PI to start to take your own steps in actually operationalising research and clinical practice. So it's a good development for yourself, and it's good development for the wider team. It's a recognised CPD opportunity that's provided by the National Institute for Health and Care Research, and I've popped a link on the slide there for further information. And it's a 6-month programme. You would, again, as Rich was talking about bespoke training, you'd work alongside the PI to work out where are your gaps, where do you want to focus your training. There will be some key bits of training that you would need to undertake, such as the good clinical practice training and informed consent, and then really working with your team about how do we identify patients and enrol patients onto the studies. And I just want to give you an example. Unfortunately, he can't be with us, but Martin Fankert is a lead spinal orthopaedic physio here at Torbay who started the Associate PI course in June. He's specifically interested in looking at the POISE study, which is being run out of Keele University, which is looking at the outcome for patients with sciatica following epidural steroid injection. So whether or not they go on to have their injection, it's a longitudinal study following them through their patient journeys. And he's seen what it's been like to actually get a trial set up within an organisation. The study formally opened in the middle of July, and we recruited our first patient a matter of days later, which was fantastic news, particularly for our research and development metrics and the targets that we are held to. We've already recruited 8 patients to the study, and it's a definite whole team involvement. So even though Martin is the associate PI, all the other spinal physios in our organisation are part of the study. They came on the site initiation visit. They're fully aware of all the eligibility criteria, and they're also identifying patients to be considered to this study. So it's a great way to, as I say, these are 2 schemes to dip your toes into research. It's not as intimidating and as frightening as you might think. So do speak to other people involved in research in your organisation, or reach out to your R&D departments. There'll be people who are really keen to talk to you and support you and provide you with loads of help. Thank you very much.
Thank you, Catherine, and thank you, Richard. And just to say congratulations on all the work you're both doing to raise the profile of research for both nurses and AHPs. I think you've done some fantastic work there. Okay, as you know, we're going to take questions at the end. So I'm going to move on to our next speaker, who's Mandy Tuckey. Mandy, are you happy to pop your slides up and introduce yourself? Thank you.
Bear with me, just trying to find my slide.
If you're almost there, Mandy, that's great, but I have got them here if you're stuck.
Are they coming? They should be coming any second now. Loading, loading, loading. Can you see
Lovely.
them?
Yes, we can see them. Thank you.
Hooray. Oh, fabulous. That's great. Sorry, apologies for that, everybody. So hello, my name's Mandy Tuckey and I'm on secondment with HEE at the moment. And previous to my secondment, I was working with the Society of Radiographers on the REPAIR project. Now, many of you may have heard of REPAIR. It stands for Reducing Pre-Registration Attrition and Improving Retention, and I looked at this project specifically in relation to radiotherapy. So in terms of what REPAIR was all about, it was really established kind of in recognition of a lot of the challenges around that recruitment, the attrition and retention of a number of different key professionals. And the original report was published in 2018, and it recognised that there were 4 distinct steps of REPAIR. And these were pre-enrolment, the duration of the course, the flaky bridge, which is the transition into clinical practice, and also early careers. And from those 4 different stages, REPAIR actually recommended 15 different areas that they really wanted to kind of work on and highlight in terms of areas to really think about how you would address those different stages. And since then, there's been a lot of work that's happened both sort of locally, nationally. We have national and regional REPAIR fellows, for example, that have all looked at how we're going to address some of those key areas that have been identified within that original REPAIR project. And so one of those projects was actually undertaken and commissioned by Health Education England through the Society of Radiographers, was how we could actually look at REPAIR through the lens of radiotherapy. So what we really wanted to do was think about how we could map those recommendations across the radiotherapy profession to really kind of see what the knowledge was, what the relevance was, and how it was kind of really being implemented within radiotherapy. And we really wanted to kind of think about how to embed partnership working and how to kind of find out how we could really share good practice amongst our professional workforce out there. So to do this, we undertook a 2-stage project. So we undertook a survey of all of our HEIs that deliver radiotherapy education, and also all of our radiotherapy clinical practice areas that deliver radiotherapy treatment and actually have students on clinical practice placement. And we wanted to survey them on all of those 15 recommendations, and we wanted to really see how well they were being utilised, how they were, what they knew and understood about REPAIR, and any kind of areas of excellent practice and perhaps areas where we think maybe there was work that could be done. So we were really fortunate in that actually we got 100% of all our HEIs within England responded, which was fantastic. And actually 88% of our healthcare providers also responded to the survey. So that was really, really great to see those results. What we did with those results, and you won't be able to see the writing on this slide, it was just really to give you a visual, is that we actually used a RAG rating, and that actually what we wanted to do was then think about the priorities in terms of importance, but also those that perhaps could be sort of quick wins. And so what we did initially is we started to think about how we could develop these into a really easy way to be able to see which ones were perhaps the ones that were most important and high priority to those that perhaps less of a priority area at this moment in time. So if we have a little look at some of these findings, I'll just kind of talk you through some of the main headlines really. It was really good to see that there were lots and lots of positives. So, for example, for us in radiotherapy, there was a really a large amount of people that had some transition to practice and some pre-preceptorship work. And we know that this is something that's really kind of taken off recently, and there's a lot of work around preceptorship. And within radiotherapy, we know that there's a lot of work happening in that, and that came through quite clearly from the survey. However, what was really interesting is that only 20% of those that were actually collaborating with their local HEI. So again, in terms of sort of addressing that flaky bridge, whilst we know that there's preceptorship programs out there within clinical practice, perhaps what there isn't is that link with the HEI in terms of thinking about how we can support those students coming through the latter stages of their degree and into that professional qualification. The other thing that was really prominent was around recruitment initiatives. And again, a lot of our HEIs and our clinical practice departments were heavily involved in lots of different recruitment initiatives. And for us within radiotherapy, that's something that we've really struggled with in recent years. We struggle to recruit, we struggle to retain, we have high attrition rates, and there's lots of multiple reasons for that. And so again, that was really pleasing to see that we were actually starting to make a little bit of inroads in terms of some of those recruitment initiatives carrying out there. Interestingly, what was really evident from the survey was that actually physical and mental health and wrong career choices were still cited as the most common reasons for attrition, and they've been cited for many, many years with us within radiotherapy. It's been well evidenced, and again, that was really prominent within the surveys that we undertook, and so that was really a key area that we really think we need to look at how we can actually address that. We also found out that actually we asked people, did they actually know anything about repair? And actually only 20% knew anything about repair. So again, there was a lack of awareness of repair and what repair was set out to achieve, and what the process was all about. So again, some work to be done around that. And then in terms of thinking about sort of culture of care, again, it wasn't standard practice across HEIs, and many HCPs didn't know and understand anything about culture of care tools as well. So those are kind of some of the key findings. The two hexagons that you can see in orange there were one of the two main key priority areas that really came out as the standalone projects that actually, for us within our profession, was something that we'd like to go on and investigate a little bit further. And they were around standardising clinical assessment documentation. And we found that 80% of our HEIs and 98% of our healthcare practitioners really wanted to look at some way of standardising our clinical assessment documentation. So we felt that that was something that really needed to be investigated in a project in its own right. The other one that came out was around simulation and the role that simulation could actually play in supporting students' clinical education and potentially supporting those already as qualified practitioners. And again, the findings really showed that we asked how much placement time could be replaced with simulation, and it came out at around 20%, and that kind of fits with what the research evidence is also saying as well. So what we then did with all of those findings is we actually developed them into key priority areas. So as I said before, the repair project has 15 recommendations. What we then did is try to simplify that a little bit and actually develop them into 6 key work streams that we formed part of a toolkit. And what we wanted to do within that toolkit was to be able to provide people with exemplars, ideas, strategies that they could potentially implement on any of those key areas that would be pertinent for them. So in terms of the 6 defined areas, we've got effective recruitment initiatives, and that included all sort of outreach activities as well. Looking also at effective retention initiatives, and this included things around student support, return to practice, strategies to increase student placement capacity. That also includes sort of simulation and non-traditional placements. So we've also seen a lot of work around sort of CPET work that I'm sure many of you have been involved with as well. There was also something around placement allocation and funding support, and again, there's a lot around students being really challenged around finding placement accommodation, how they can fund that placement accommodation, how they can regain financial compensation for any sort of travelling, that kind of thing. As I've mentioned, the standard clinicalised assessment documentation and also preparation for practice, and that kind of included preceptorship. So what we then did is we began to populate our toolkit with some examples from our stakeholders, because what we found when we undertook our in-depth focus groups was actually there was loads of really good work out there. And what we wanted to do is be able to have a central repository where we could really kind of enable people to go and find out things that would be really, really beneficial to them, and that might be helpful for them to kind of implement. So some of the examples that you can see here was around looking at retention initiatives. We have within radiotherapy, particularly within the Southwest, we have what we call a mid-placement focus group. And what students were saying was actually they have an opportunity to feedback on their placement experience after that placement, but actually there was no opportunity for them to be able to change things if things weren't going well, or conversely, if things were going really, really well and they wanted to make sure that others had that same experience. So they implemented a mid-placement focus group, which was a really good opportunity for students to really kind of feel supported in enabling them to be able to say what was really happening, what was going well, what would they like to be able to do differently, so that if there were any issues that were identified, they could actually implement change before the end of that placement. And we were then finding that it was having a much more positive experience on that student placements experience, which is really, really great. And again, a lot of places say, oh gosh, we can't increase student capacity, it's just impossible, we're up to our max. And so we've given some examples of some possible timetables where you can see how you can shift the student working pattern depending on what working hours you do and what sort of work the student may well need to be involved with in a given day. And also they're an example of a leadership placement. So again, thinking a little bit about leadership is something that we are introducing to our students right from the get-go, right from the beginning of their training, right the way through to their professional practice and beyond. And so having some leadership placements is a really good example of how you can kind of start to get the student to think a little bit about the importance of leadership, not only of themselves, but also of others in the organisation that they're potentially going to be working in as well.
Mandy, you have 1 more minute.
Perfect, because this is my last slide. So where do we go here? Well, we've disseminated the findings. You can access the report. The link is at the bottom of the screen there, and it is available for everybody to see. We are in the process of hopefully setting up a special interest group whereby we will invite people from not only just radiotherapy, but across multiple professions as well, to be able to come and share good practice, ask questions, and really as an opportunity for them to be kind of really give us some showcase examples that would be really, really valuable. And so I've just popped our contact details. It was Nikki that I worked on the project with. But as I say, if anyone's got any questions at the end of this, then please feel free to ask. And that's me. Thank you.
Thank you, Mandy. That's great. I have to hang on to my question. Thank you. Thank you. Okay, so our final speaker is Amy Caulfield. Amy, I think I've seen you in the room. Are you happy to introduce yourself and put up your poster and talk us through it? Thank you. Are you with us, Amy? I can see Amy's in the room and she's not muted. Amy, are you? Can you hear us?
No, we can't hear you, can we?
We can't hear you, Amy, sorry. Nope, still can't, still no sound. It looks like you're muted now. So now you're not muted, but we cannot hear you.
Amy, it might be set up for a different audio. Have you got headphones that have been plugged in beforehand or not? Sometimes that can change the way that the audio settings are set up.
If you go to more at the top, Amy, you should be able to get to device settings. If you click on device settings, it should come up with audio settings and just see what it says in your microphone in case there's anything in there.
We still cannot hear you.
Do 10 minutes of questions, Rhoda, while Amy's trying to sort and perhaps come back to us.
Yes, that's a good idea. Thank you. Okay, so I could see we've already had one question in the chat, which was aimed at Mandy. Mandy, I think Abby was asking about the transferability of your findings for the repair project on other AHPs. Have I understood your question correctly, Abby?
Yeah, sorry, I've just press the reply just as you said that. So yes, absolutely, lots of transferability. And in fact, what we ended up doing was talking to lots of other professional groups who potentially had already implemented some of the things that came up in our report. So we talked to the physios about their standardized clinical documentation, because we know that's something that's happening within physiotherapy. We also spoke to nursing colleagues, and we also spoke to other AHPs that have looked a lot around buddying and mentoring and supporting of students in clinical practice, because we know that those terms are interchangeable and they mean and do different things, but we really wanted to kind of get to the heart of how do you actually effectively support that student. And so yeah, we talked to other different professional groups, and that was something that we really want within our kind of our special interest group, is to be able to kind of draw other professional groups in, really. But there are still the regional repair fellows, but in terms of whether each individual AHP profession is looking at repair, I don't know, is my honest answer.
Thank you. Thank you. Amy, should we do a quick sound check in between questions? No, still can't hear you. Okay, we'll take a couple more questions and then come back. Abby, I don't know as well if we can look at whether there's space on any of the other programmes later this week. If we are unable to hear Amy today, could we have a look at that while we're taking questions? Right, I can see some hands coming up. Matt.
Thanks, everyone. It's a question to Richard and Catherine. Thank you for your presentation. It follows on from some of the talks we had yesterday, which were, we had so many great inspirational talks like we have again today, and there's really good work going on. But it was this idea of how do we celebrate that and share that? And is there a way of putting that together, you know, within an organisation or a system level? Because it's just that it felt like, certainly I work in a pain team, and I know my doctors and psychology colleagues would definitely be doing it, but we just don't seem to be as good as sharing and celebrating and promoting that. So any thoughts on that?
I'm happy to go first, Rich, and you can have a think as well. I think the two things that I spoke about, which the Chief Nurse Research Fellow and the API scheme, the Associate Principal Investigator, I think for us now, as Rich was saying, getting the chief nurse, getting an executive person aligned to this opportunity, I'm really hoping will help with our profile, because we're getting an organisational recognition of this opportunity, which up until this round of applications has always been something that we've sort of limped between trying to apply for little pockets of money. And I'm really hoping that by getting more organisational engagement in it, our Chief Nurse Research Fellows get protected time with our Chief Nurse. So that was really what we're really trying to do, is to bridge that gap between research and clinical practice. And we did a bit of a launch. I think it still feels we're a little bit sort of still post-COVID in terms of trying to get people together. So that is a real barrier. I think there's so much to be said for physical meetings. They make such a massive difference. But what I would really like to do, our next stage really, is to really try and engage our associate directors of nursing and professional practice even more than some of them already are, about really promoting this award. So we're almost creating an organisational expectation that every year which associate director is nominating and putting forward their candidates to be considered for this award. We're trying to make it a prestigious award that then will demonstrate then overall organisational improvements in practice. The second thing was about the associate PI scheme, and really unfortunately, not due to COVID but due to operational pressures, we were supposed to have a physiotherapy forum meeting, I think maybe it was last week, or only on Tuesday last week, and it was going to be such an exciting opportunity to finally get physiotherapists together after such a long time during COVID, and Martin and I were due to speak about his experience on the associate PI scheme, really promote that. The other thing, the reason why I've got my hand up, which I'll lower it down now that I've actually got the floor for a second, was that I'm really keen to look at how we could use the associate PI scheme for things like ACP and development. And actually, rather than necessarily saying that people need to go and do PhDs, if you're not interested in that academic side of research, there are other aspects of research where you, as a leader in your profession, AHP nursing, whatever it is, can really make a massive difference to bringing clinical trials into your practice, demonstrate leadership in your team. And that was going to be part of the main thrust about us speaking at the Physio Forum last week, which I'm really hoping is going to get rescheduled. But I mean, I'm sure Rich wouldn't mind me saying that both of us are free to rent out. We'll come and speak to research about anybody, to anybody. So do ask us. We will come and share these good news. And what's great is that we've got some fantastic good news stories. I'm really pleased to see Becky Striders on this call, who's one of our very first research associates. And by having these people embedded in their clinical areas, they also start to become the champions. The reason why we've got a Chief Nurse Research Fellow in CT radiography now is because of the work that Becky's done previously. So success will breed success, trying to sprinkle this across the organisation to really build a growing movement. I don't know, Rich, if you want to say anything else about celebrating. Thank you.
Have we got time?
You've got a 1 minute, Rich.
1 minute. Matt, really good question. And one of the fundamentals of any researcher, clinical academic, is learning how to disseminate. And that is part of the process you go through about learning your audiences, how to present, whether it be poster, whether it be to a conference, to international, regional, and how we facilitate that is in different ways. But I think regionally, you've identified we've got some great ideas both yesterday, today, and we're going to hear it all week. But how do we celebrate that? How do we notify it? Do we have to wait for AHP week every year to get? And this is only just the tip of the iceberg, in my opinion. I know there's so many more things out there. And you're right, how do we then start to collate, demonstrate, but evidence, because that's how we're going to shift care.
Thank you. Thank you. Amy, can we hear you? Can you test? Okay, no, we still can't hear you. I think we're going to have, Amy, I think we need to pick up outside this meeting whether it's possible for us to rejuggle you a little bit later in the week. I'm so sorry we can't hear you.
Rhoda, Amy Sister has agreed that she would present today if Amy could do tomorrow, other Amy could do tomorrow instead, or either that, Amy Caulfield, you could do Thursday or Friday instead, if that would suit. Yeah.
Okay, so we have an offer to fill our final 10 minutes.
It's up to you, Amy. I don't want to put you on the spot, but if you're happy to present today, then go for it.
Hello, is my mic
Hello.
working?
Yes, you
okay,
are.
well, hi Amy, hi. I'm taking the Amy slot. So I've prepped something. I hadn't had a time to run through it, so I was going to come in today and have a watch of some before tomorrow, but I'm happy to. It won't be as highbrow as what I've just heard. It's about physios in global health and sort of working abroad, so maybe I can finish your session just with some holiday snaps, perhaps. I don't know. If that's all right. So let me see if I can share from here, and if I can, then I am happy to go for it. If I open my PowerPoint up onto this screen, can everybody see that?
Yes,
anybody
we can.
see that?
We just need it on slideshow if that's
yep.
possible. Thank you. Perfect.
We're in. Oh, it's given. Oh, right. That's okay. So for my side, it's put me on a presenter view here. So just bear with me. I'll just be stuttering a little bit. Okay, super. So I can't see anybody now. Sorry. So you have to wave at me if you've got your hands up. For some reason, I can't. No, it's going to make me do it. This is what I was going to try 9 out earlier. Okay, so I would just like to tell you a little bit about some international physio work that I've been doing, and just basically some holiday snaps about what I've been up to in the last 5 or 6 years, and what opportunities physio has opened up for me to be international, what opportunities it can open up for anybody to go and work internationally if they're interested in it, and what a valuable resource and opportunity it is. So just me a little bit. So I qualified in Manchester Uni 2005, moved down to Devon and started my rotations, and here I stay. I started band 6 post in Oakhampton in 2009, and have been very, very lucky to be supported through that entire period of time to do some work abroad, do volunteering posts, take annual leave, and I was supported to take a career break as well, which allowed me to go away for a significant period of time and do some work with amputees, which I'll talk about in a minute. So really well supported by the RD&E or RUDH, but as it was, so been really well supported by the trust throughout that period of time to be able to go and do these opportunities. And I've currently just moved to the GP surgery for the PCN team, with a sort of FCP role in frailty, and I work as a lecturer at the University of Plymouth as well in the other time I have. So I know Christy and Vaz were earlier on, but I don't think they're still there now. So some of my lecturing team are on as well. So where I've been in my varied past career. So I spent in 2010, I went to Colombia and spent a month learning Spanish in a military hospital, which was really interesting to see the amount of money the military hospital has and how they work their system. So I was obviously quite sort of fairly newly qualified physio at the time, and having a system where anybody could turn up with their x-rays in their hands, and the physios would then sort of look at the x-rays and sort of interpret the x-rays from a bit of paper and then decide what they wanted to do next, whether they were going to use manual therapies or they're going to use pulse shortwave, ultrasounds, all that sort of stuff that MSK used at those times was still being used in Colombia. The military hospital was very well, has a lot of money, as I suppose you could imagine. So it was the patients were in the civil conflict as it was at the time and were expatriated back up to Bogota Colombia Hospital. So I got the opportunity to see sort of ward work, to see MSK gyms, to see treadmills, to see equipment in that environment, which was really interesting. I did a little piece in Frontline about that, but that was many years ago. I can hear, if you want to talk to me, somebody's going to have to talk because I can't see anybody's camera. So if somebody wants me to stop or go quicker, you'll have to, I can only see Rhoda.
No, it's fine. It's fine. I think we'll just need to make sure we're muted. Thank you.
Okay, that's all right. Just because I can only see you, Rhoda. So if you need, give me a wave. And then I was lucky enough to join the Kenya Orthopaedic Project and spend 2 weeks in Kenya in 2013. So this is a trauma and orthopaedic project. So it's sort of MSK, a little bit of TNO in Colombia, then TNO in Kenya. So that was a team that flew out from Torbay Hospital, so consultants, orthopaedic consultants, anaesthetists, trauma ward, trauma theatre staff, plus a couple of physios as well. So we went out, and they had a really good sort of teamwork system set up in Kenya, where the receiving hospital staff. So I went to Nanuki for the first trip and Nahururu for the second one, and they got it as a really, really positive job exchange. So the Kenyan staff came to the UK and did some sort of shadowing and work in the UK, and we went to Kenya. So it was really, really, really good to see the links and sort of sustainability of those projects, that actually what was taught and what was done within those 2 weeks was carried on until the next time the team went to visit. So it was a really positive sort of work. You know, obviously with global health, sustainability is really important. So not just going and doing something and leaving again, actually looking at the relationships built up with the teams, and how they all work together and how they kept that longevity and that sustainability was really, really, really interesting. And I got to go again in 2015 with roughly the same team to a different hospital. So this particular charity has got sort of 3 or 4 different hospital teams they work with within Kenya as part of their project. So again, for me, as sort of as a band 6, but it was for me, I learned a huge amount of stuff, and also looking at sort of different global health things and the amounts of diabetes and back pain and knee pain and arthritis that actually is sort of a global problem that actually I've got the skills to deal with, even if I might be in Kenya. So sort of having the confidence and the travel bug from having these trips, and the option from the RD&E to do a career break, I spent 9 months in Bolivia in an amputee charity, which was also fascinating, and that meant I got to work alongside a Bolivian prosthetist and a Bolivian team, and spent 9 months in the year doing amputee rehab. I took a PAMAID out, so I took a PAMAID through Miami Airport, so I can only imagine how that went down. To explain what's in the bag, madam? A leg, sir. So we managed to get that through to Bolivia, which is brilliant, and train them up to how to use the PAMAID. So that was a really fabulous thing to be doing. I'm going to rattle through these because I've got some photos to show you as well. So then the last couple of projects I've done more recently are both part of a charity called Prosthetica. So I spent 2 weeks in Guyana doing neuroorthotics, and then a week in Guyana this year using PAMAs. I'm a little bit of an amputee nerd. And then I got called to see if I wanted to go to Gaza in July, and off I went and did a week of training in Gaza Strip for neuro rehab. So just a little bit of interest, just to add a little bit of interest into it really. So I think I've talked too much already about Kenya, but the trauma and orthopedic options were sort of seeing the hospital, seeing what facilities they had. I got the lucky enough to be able to go into surgery and see some stuff in theatre, which is obviously not as easy to do within the NHS remit if you don't work within that. So some of the Bolivia, so I got to do some paediatrics work. So the chap in the middle is John Barstow. So it's his charity is Prosthetica. He's an American CPO. It's on the ISPO, so the International Society of Prosthetics and Orthotics site. He's written for the World Health Organization. So he does lots of these projects, again, really focusing on sustainability. So going out and training local people, using equipment that they can have access to, using teaching skills that they've got the machinery to use. So all this kit that you can see in these photos is all bought and made in Bolivia. So all this stuff is a sustainable work to be done. But also we're doing it outside in the garden and on tops of tabletops and stuff. While I was in Bolivia, I managed to find some horses. So those of you know me know I'm horse obsessed. I managed to find some horses. So at the weekends, I popped down to a place called Jupipina, just outside of La Paz, and helped with kids with cerebral palsy, doing horse therapy, hippotherapy, and also teaching kids with autism to ride. So that was just a little bit on the side, but just an absolutely amazing experience that, again, I haven't had the chance to do in the UK, but learn a huge amount of paediatric just from that experience, and learning using horses to work with kids with learning difficulties and with autism. So actually I taught them all dressage tests. I had all the autistic kids came into my class and one of the sessions, and they all learned to dressage test. So because it was all circles and directions and numbers, they really enjoyed it. And so by the end of their 10-week course, they had to write the dressage test and then salute the judge at the end, who was the doctor, and then they got a certificate, and it was just gorgeous. So then neuroorthotics in Guyana. So this is John's. You see John in the middle. He sort of cameos quite often in my photos because he's quite an amazing hero of a man. So these are the prosthetic and orthotic team. You can see him in Guyana. The chap in the grey is Eddie, who is a CPO from Guatemala. So a real international team again that we were going out there and doing that. This is where my lecturing enjoyment started. So you can see the bottom left picture. I did a bit of some lecturing, so I took some slides over and did some teaching as well. For neuroorthotics, did gait rehabilitation, looking at gait patterns and how to decide when and what to refer on for neurosplinting. So really good experience, because the orthotists and prosthetists and the physios all came together to join this training. And Guyana is quite a small, well, it's not a small country, it's quite a small population of people. So we had every single physio in the country come along to the training, which is a phenomenal way to do sustainable training and actually do things that you can build relationships with and manage. Yep, two more. So this is second trip was this year, PAMAding in Guyana. So again, took the PAMAd out. So they've now completely changed their amputee rehab program, and they have 2 afternoons a week where they do below knee 1 week and 1 afternoon and above knee the other afternoon. They use the PAMAd every single week for rehabbing their patients. It's been an absolute game changer for them. And then last little bit really was in just went sort of ad hoc as a last minute addition to some neuro teaching in Gaza, which was a completely different experience for completely different countries, completely different issues going on. So for me was, again, a really interesting but very different experience. So summary, I have aged, sadly, throughout this photo album, but it's led me to be a committee member of ADAPT, the International Physio Group. It's helped me do lots of conferencing and stuff on this side, so organising some MDT conferencing this year. I've did my amputee MSc in LMIC rehab, so that was certainly something that spurred me on with my clinical role and my interest as well, and had some articles on agile frontline and back par. Hopefully joining with one of my colleagues to do a book chapter, and I want to get my MSc thesis published at some point. Slightly over my time.
No, Amy, you're fine. Thank you so very much, and thank you for stepping in at such short notice.
Right.
We have 1 minute to take any quick question.
I can see you all now.
I can see there's some stuff in the chat just about how inspirational that is. Mandy, your quick question.
Just very quickly, how do people go about volunteering and doing the stuff that you do? How do How do you do it?
Really good question. Actually, we taught the students about it as well in the career stuff. So it's a lot of it's networking. So the ADAPT committee, if you're interested, so the physios ADAPT, but we will have whoever wants to join in the ADAPT. So that is the first place to go for physio networking. And the ADAPT will send out emails about jobs that are going, emails about volunteers that are wanted, link internet. So I ended up going to Gaza because one of the ADAPT committee members that I'm with messaged me in June and went, we need a neurophysio to come to Gaza, are you free? And I was. So that's how I ended up in Gaza. But yes, so really networking and having an interest in it. So the ADAPT is the first place to go. We do an annual conference, which is at the end of this month or beginning of next month. So on Twitter, it's CSP_ADAPT. So we've got a conference coming up, which again is a way to sort of see speakers from here, there and everywhere. But that's the best way to get in it, is networking. It's really. So you see John sort of appeared throughout those photos. Like John randomly turned up in Bolivia while I was there. So then I got involved with that. And then I went to Guyana with him. So a lot of it is just who you sort of come across doing it. And then the bigger your sphere gets.
Thank you. Thank you. Thank you, everybody. I'm going to just take the opportunity to thank all our speakers because we're just about out of time. I feel incredibly proud of everything I've listened to. It's been great to hear about the work that Mandy you've done in terms of early careers and supporting people. And then I've been really blown away by all the other examples of career choices. So thank you, Rob, for sharing your journey into what's been a very traditional nursing role. Thank you, Catherine and Richard, for the work you shared about the work you've done about careers options for people. And Amy for wrapping it all up. It wasn't intended, but that's fitted really well with that session about global health choices. You are all completely inspirational, I have to say. Thank you so much for sharing with us. And thank you everybody for joining us. I hope you all have a lovely afternoon and have a wonderful rest of AHP week. Thank you all.